So I have the most boring slides, no charts and graphs. But I'm a primary care doc. 60% of my time is spent in the clinic seeing patients. And so being in this room is a little intimidating because most of the folks here are at big academic health centers. Our health system has 6 hospitals, 3 of which are critical access. 1 is too small to qualify to be a critical access hospital, covering the 17 most western counties in North Carolina. And our biggest focus right now is mitigation of a deficit and how to work on that. And so my perspective is a little, that I'm going to try to present today, is somewhat driven by my clinical experience. I see telehealth patients in 2 venues. I see them through our school-based network, which is live, interactive, and then also I provide care through our direct-to-consumer platform that is a guided, adaptive, questionnaire-driven package. So I have some real-life perspective of providing care. But as I think about my colleagues and this concept of research and doing research, well, we get kind of intimidated by the word research. Most of us who did primary care residencies, maybe we did a PDSA cycle somewhere in the process and we checked blood pressures a little bit better the next month. But we have not engaged in real research. And we run into this problem thinking that, well, research is solving a new problem. You know, you went out, you invented a new method to get something done. And then you ask, well, am I doing program evaluation? And sure, if you're looking at any of your data, you're doing program evaluation. We do it under the auspices of our ACO metrics every month, looking at flu vaccine and control of blood pressure. And then, well, where does quality improvement fit into this? Because that's another word I hear sometimes. And if you take that program evaluation and apply it, it sort of becomes quality improvement. You know, Brendan earlier mentioned feeling that if you hadn't done surgery, you probably shouldn't operate. And those of us who have minimal practical research experience, maybe we shouldn't be guiding research projects. And that intimidates us in even entering this realm. And so with our telehealth program, we have used SurveyMonkey to collect data that we can't extract from our EHR. And so we look at a wide variety of variables. We've got 3 years of data on did this child or teacher return to class or school. I don't know if I can share it with Elise because it wasn't IRB approved, and I'm scared of an IRB. And gosh, we've got a really nice patient satisfaction or parent satisfaction survey we did, but that's probably more quality improvement because we didn't put it through an IRB and probably can never publish that data. But these are the things that we encounter, that when you're an independent nonprofit or a small hospital system or a private practitioner out there, it's really hard to be engaged and think about yourself doing research. So the next thing that happens is, well, how do I translate existing research in telehealth into my own practice? I don't know of any of my colleagues who have read the 126-page AHRQ report. It's interesting. I liked it, but I'm a geek at times. And yesterday, Joe McMenahan talked about 17 years for research to go into practice. Well, I think Joe was expanding his definition and saying bench research into actual change in kidney care. It's faster than that, but still, for telehealth, the primary care physician sees popular press articles as opposed to real articles. So we see Lori's recent article, and well, telehealth raises costs. And there was another one about 2 years ago out of Britain that said telehealth raises costs for remote home monitoring. It was added on top of standard services as opposed to being instead of or in a replacement for or integrated with. And so because the cost shows up, and because we then say, gosh, these are really expensive systems to implement, it's very different than me saying, oh, well, proton pump inhibitors are now being shown to decrease patients' level of magnesium. I should switch everybody from Prilosec to Zantac and avoid that. That's a really simple thing I can change on my own. But I'm not able to change how I do remote patient monitoring within this concept of a small health center. So this idea of translating research into what I can do in my office is intimidating for myself and for other providers. And there's a solution here that I mentioned to John Chu. John had to go to a phone call, but when we were talking about this. And what I feel we need to do as an organization is to engage practice-based research networks. Before I said that word, how many folks in the room had actually heard of a PBRN? Great, not a lot of folks. There's a large national network, AAHRQ, I'm giving another plug here, leads that effort with 8 coordinating sites, and 50% of the sites work in rural practices. So an example is Oregon has a strong PBRN. Oregon then has 25 practices across the state that are engaged in some type of research. And when they want to look at something, they can reach out to them. So they've done one study on telehealth, and it was a quality study of rural physicians and their sense of what is, of remote home monitoring and the effectiveness of it. But very little PBRN research that I could find, and a quick search, not using Google, engage telehealth or connected health in any way. But I think that's a place that as we grow as a society, we need to make that reach towards. And then finally, one of the challenges we always face is we've talked about it a lot, this onslaught of new products at the same time that we can't evaluate the research in an objective manner. So what do? Well, somebody comes to me and says, oh, we got this great remote home monitoring product. And I go, who's using it? Let me go talk to friends in the field and get their impressions. They say, yeah, we like it. We're real happy with it. Of course they did. We invite 4 vendors in, and they say, we've got all the bells and whistles you could ever want. And we finally go with one, and we go with this technology product, but we don't have the workflow in place to really make it successful. And that can be a challenge at a federally qualified health center, at a small private practice, and at a moderate-sized health system like our own. So how do we partner to get better information around the products we do purchase and invest in? And Judd brought up a great point yesterday where he said, we need to own our data. So we've got this virtual care platform. The company provides an analytics portal for us, but the analytics portal doesn't answer all the questions I want. I could probably get some raw data around actually what antibiotics are being prescribed, and I'm not in a place where I have the time to analyze that data. So again, I've got the information perhaps at my fingertips, but can't get it out there. And so these are the things that intimidate us in the primary care field about engaging in research. Marcia mentioned it, and Judd has mentioned it in the last session, about this framework that we've been working on with the National Quality Forum. And to make my role very clear, I sit on the side and I make difficult comments and let the experts in the room make the decisions. But Judd and Marcia chair that process and have done an excellent job, along with Jason Goldwater at NQF, who's brilliant. And so this was really tough conceptually because it's the design of a framework for creating measures, and as opposed to creating measures themselves. And I wanted to dig into it because I think that the framework from the NQF can also be used in program evaluation at a level as small as your own, as a small practice. So when we began thinking about it, we created 4 domains. We actually had 5 initial domains, and then when everybody got back together last month, we narrowed it to 4 domains. And the first is access. As we think about all the projects that have been presented here and all the research, I really feel that you can put every measure that they're using into one of these 4 domains. And so as we talk about access, it's access for families, it's access for the provider, and one of the most important things was access to information. That EHR interoperability and the extension thereof, how do we enroll the patient in Spruce Pine and have them be seen in Chapel Hill and know that the information is valid in a research study or in a process improvement process in your own institution. Then looking at financial impact and cost. So the distance, the time away from work factors, the care team. So and Is it actually of greater cost to provide that service? The gentleman from Columbia Presbyterian said their virtual care platform had cost about $50,000 a visit so far. And that's, an expensive cost. And then also the cost to society. So the new paper out of UC Davis that actually measured carbon impact or calculated carbon impact. And also, are we making a difference in the population as a whole? And then thinking about the experience, and this is where our small needs assessment survey comes in, and that we've been doing for parents and teachers that we see through our school-based telehealth network. And what's the experience? But what's the experience for the care team? I'd really like to take a look at what's the experience for our school nurses having this additional tool there. And then finally, what's the impact on the community? How do they feel about themselves? How do they feel about having telehealth? And does it change their perception of the value of care provided at their critical access hospital because there's telestroke, telepsychiatry, and telepodiatry now available? And then finally, the effectiveness measures, looking at the system as a whole, looking at clinical effectiveness, looking at operations and technical effectiveness. So how do you look at, does your network stay up? So we looked at that for 3 years in a row in our school-based program. Were you able to complete the visit? And were you able to complete it without needing to use a workaround? And for the first 2 years, over 10% of our visits were terminated early because of technical problems. We switched who we got our technical support through, and all of a sudden that number's down to like 1.6%. Again, not sure if those are numbers Elise wants for her data, but these are this is the framework where I think that we can begin looking at program evaluation at any level. And I'm happy to share these afterwards since they're on 4 separate slides. Thanks.